session 2024. I am Arup Chakrabarti, the senior instructor for this course. You know, it is a cliche to say that cataract surgery today is a refractive surgery, and we want to hit the target refraction each and every time you operate. The holy grail is, for most of us, is to hit at 6.6 plano. And where are we today? So there have been a couple of studies looking into this. I think I'll be quoting a very important, really relevant study published by my friend Giacomo Savini. So here the data captured was using a swept source OCT-based optical biometer, and all the current formulas were compared. And the study showed that all the new generation formulas landed within a plus minus 0.5 diopter of prediction error, 88% to 90.67%. So this is for routine eyes, not challenging situations. We'll be talking about challenging situations throughout this course. So if we have not reached this level, means we have a long way to go, and this course will become relevant. So I'm proud to have Dr. Nirupama. She is the professor head of the department and JIPMER, very young, dynamic, very brilliant surgeon, brilliant academician. Then Kumar Doctor. He always rides, you know, the new technology, the wave of new technology that comes, and he's a good friend. Ramesh, he is a pan-ophthalmologist. He is able to talk anything on any topic with the latest references, and you know, it is amazing. Then Atul, my young friend, who during my COVID days when we had a lot of online activities, so I went on to discover his brilliance. You know, he's academic, as an academician, as a surgeon, as an innovative surgeon, and as an organization, as an organizer, in the sense that he has been president of Vidarbha Ophthalmic Association, Amravati Ophthalmic Association. Now he's the secretary of Maharashtra Ophthalmic Association. Dr. Suven Banerjee, Suven Bhattacharjee, who was a couple of years my junior during my MBBS and MS days in Pondicherry. So now he doesn't require any introduction. You know, everybody knows him. And Dr. Meena Chakrabarti, who is a VS surgeon. So this is the timeline. This is actually the course, the topics that we'll be covering. And my topic will be just the SOPs that I have been following. Every year the SOP changes a little bit depending upon publications that have come in, depending upon the results which I have been obtaining with my refractive outcomes. So what I have realized that IOL part calculation is just not something to be treated as a test that has to be done in the preoperative period. It pervades the entire, preoperative, intraoperative, and postoperative period. You do certain things intraoperatively properly for you to hit the target refraction. Postoperative period is the moment of truth, so you know where we have reached and what are the precautions you need to take, what are the course corrections you need to do. Last couple of years, we have realized the ocular surface is very, very important. And, so if the ocular surface is suboptimal to start with, your IOL calculations will go haywire. Monofocal lens or a multifocal lens, you'll be landing farther away from the target refraction. And if it is a toric IOL, then of course, you have a wrong axis calculated and wrong IOL part calculated. So your results will not be very optimal. Another thing that we need to do is all investigation should be done on a virgin cornea. So a patient comes in the morning and you do the biometry after doing all the tests, you're not going to get a good outcome for this patient. Anything?
The slides are changing. Just 2 seconds.
Slides are not changing? So shall I do the presentation all over again, or? Yeah, it is okay now? No, I'm doing that. Otherwise, how am I going to the next slide? I'm clicking on the next one. Tell me now it is not moving. It is not moving. Okay, I think, I would not, for the sake of time, I won't repeat whatever has been gone, but I feel things should have been better organized. Someone should have looked at the screen and ensured that these two are synced. It is very unfortunate. So this is actually the topics that we're going to be covering. And I have already mentioned that I'll be talking about the SOPs that I follow. And my SOPs basically depend upon what refractive outcome I'm getting in this particular year, and then what are the new things that have come up in the literature, new suggestions and new tips, then I incorporate them. So my first tip would be, please ensure that don't consider IOL power calculation as just a one-off event in the workup of the cataract patient. It is something which pervades the intraoperative period as well as the postoperative period. And ocular surface, we have realized for the last couple of years, is very, very important in this context. And if the ocular surface is suboptimal, and it may result in poor refractive outcome, both in terms of more monofocal or multifocal IOLs, or tonic technology where you get a wrong axis and wrong IOL power. So it really messes up with your postoperative outcome. So if your patient has an ocular surface issue, that has to be optimized, and then biometric readings have to be taken. Third point that we do is, we never do the biometry on a cornea which has already been, where procedures have been performed, where you have dilated, we have done an ablation tonometry, or any contact technique has been used. So that should be done as the first thing in the morning for the patient. I had realized that when I was doing ultrasonic biometry, then in certain cases, I won't get a good value if I don't dilate the pupil. So I have been dilating those patients when I used to do ultrasonic biometry. Then recently I found out a paper where it has been recommended even for those who are using a swept source OCT-based optical biometer. So this particular study, this is with IOL 700, 8.52% of cataract surgery candidates had preoperatively low quality biometric measurements because of dense cataract. So these were dilated, and repeat axial length measurements improved. The quality improved in 75.95% of the patients. So sometimes, if you don't get a good quality measurement, I would dilate and then do the readings. But another picture comes into the mind. Whenever an eye is dilated, the biometric parameters are known to change. So multivariate formulas, like all the modern formulas, they may give different results. See, there are plenty of articles, plethora of literature. So after dilatation, if you see carefully here, the central corneal thickness increases, the anterior chamber depth increases, lens thickness comes down. So if we use the biometric parameters obtained after dilating the eye in the modern formulas, you are expected to land up in calculating a lens which is half to 1 diopter higher. So patient will have a myopic outcome. So I always tell these patients that I'm dilating your eye, and for me to get accurate results, but in 25% of the time, I may be off the target refraction, a myopic error by 0.5 to 1 diopter. So a patient is counseled accordingly. And sometimes when you don't get good Myers, in particularly patients who have ocular surface disease, you thought you have optimized well. So we are in the habit of putting a lubricating eye drop. It is a universal phenomenon. So if you are doing that, then you use a time period of more than 5 minutes after you have instilled the eye drop to repeat to get the biometric parameters. Now, what are the devices that one should be using for obtaining these biometric parameters? I use an optical biometer. I also use a topographer and eye trace, and always make sure that if the patient is using a contact lens, that has to be removed at least 2 weeks if it is a hard contact lens before the biometric procedure. A manual keratometer, an auto keratometer, or such devices definitely are also, they give very good results. Please do not use immersion A-scan, the contact A-scan. If you're using ultrasonic biometry, use only immersion A-scan, because we know that the results with immersions, with contact apprehension biometry, ultrasonic biometry is much less accurate. There's a mean average shortening to the tune of 0.25 to 0.33 millimeters. So this is a meta-analysis done by the late Hygis, where he compared optical biometry results versus immersion, and they found out that optical biometry still gave better results in terms of the postoperative prediction error. The optical biometers have been improving. We have now new generation, which are swept source OCT-based biometers. Those of us who are still using the older ones, so then I use the IOL 500. I've been contemplating whether to change to a higher one or not. But those of you who are using the basic ones, studies have shown, various units have been compared, and they have shown that, they are quite, there's got great deal of repeatability and agreement between the different systems. So it really doesn't matter which biometer you're using. And if you're using, whether to step up to IOL 700, there was an article about 9 years back which showed that, both those devices do extremely well in terms of the accuracy and predictability. However, IOL 700 has certain additional features, harder cataracts, posterior subcapsular cataract, lens tilt, and then, you know that you're measuring up to the fovea. So these are the posterior corneal measurements. These are additional features that the machine gives you, but IOL 500 is also pretty much accurate. Then another thing we need to bother about is, just because one is using an optical biometer does not mean that you're going to get fantastic results. There are validation guidelines for each biometer, and these actually are very, very, they're very important. They're a little complex, so I have taken a printout. It is in the optical biometer room. So whenever the validation guidelines are not fulfilled, that particular scan has to be deleted, and the examination has to be repeated. Hard cataracts, optical biometers like, IOL 500 doesn't do well. So if the fellow eye has a immature cataract or a pseudophakic eye, I do an immersion scan as well as optical biometry in that eye. And if there is a good degree of correlation, then I assume that, my ultrasonic biometry, immersion biometry for the hard cataract eye is more or less, reproducible, and I repeat it once more and then accept that value. There are newer formulas that have come up, and we have, the current formula is Hoffer QST, which is actually uploaded in the ASALS website. So I basically still stick to Barrett Universal 2 for my routine cases, because it is a suite of formulas. All refractive requirements are taken care of by this particular formula. This also can be used if you have used an immersion scan or even a contact scan with ultrasonic biometry. Only thing is, the A constant has to be proper. It will be written on the box what should be the A constant that should be used for ultrasonic biometry if you have done the contact biometry. So this has to be kept in the mind. Kane formula is a new kid in the block. It does well for a variety of situations. I use multiple formulas when I'm dealing with extremes of eyes, short eyes, long eyes, and things post-vitrectomy eyes and things like that. So it has given me good results. I find that it is better to use 3-4 formulas in these complex situations and find out what exactly is the IOL path that I should be using. Make sure that the rexis is always central and it has a uniform overlap on the optic margin. And if a patient is coming for surgery for the fellow after a couple of weeks, I take advantage of the refractive error that has happened in the eye that has been operated. So there are certain conditions that have to be fulfilled. Both the eyes should have intraocular symmetry and few other conditions. So I would adjust the target refraction for the fellow eye to the opposite power, and about 30% of the Barrett's Universal to whatever I get with this. So this is an adjustment that I made. And newer formulas have second eye enhancer. Gender also plays an important role. Barrett Universal 2 is supposed to be more accurate for males, and the remaining formulas are more accurate for females. So this is also being taken into account in the newer formulas. So friends, the SOPs keep changing, and but you need to be always abreast of the newer developments that are coming up. Use validated measurements, work with properly optimized lens constants, adapt to new technologies as they present, employ the right formula, and strive to use all available resources to their best advantage. Thank you very much for your attention. So, Kumar, you are going next? Yeah. Oh, I'm so sorry. My apologies. Okay.
Last one. At the onset, I would like to thank Dr. Arup. There was a crisis in the morning. They don't allow you to connect the laptop, and then you have to convert everything to Windows. This happened to me about 15 years back at the ACRS, where there were 2 Apple computers and 85 Windows computers. And now if you go to the ACRS, there are 95 Apple computers and 2 Windows computers. And in this conference, we are not allowed Apple computers, so it's interesting. Anyway, I hope all my slides work. Recent concepts in post-refractive situation is what I'm going to say. So this happens to all of us when this situation comes. And as time goes by, I'm doing LASIK since 1999. So a lot of patients are coming back due to having a cataract, and then the confusion as to what to really do. So there is a rise, no doubt, in post-refractive number. And IOL calculations, it is known that keratometry results in 27% of the error. IOL misalignment is 14%, IOL tilt is 11%, and angle kappa is 7.5%. So keratometry does play a very important role, and if it's a post-refractive case, it will play even a bigger role. So what to look for? Yes, we have to look for corneal shape, very important, corneal power analysis. So now we all talk about total corneal power, topography, tomography, angle kappa. Dominance used to play a role. We used to always look for non-dominant eye and dominant eye depending on the ad of the IOL that we want to place for the patient. But now dominance is not because of the new trifocal IOLs. Dominance does not play that important a role because it's a non-dominant eye, you'll still use a trifocal, and you have a dominant eye, you'll still use a trifocal. Of course, you have to look at corneal aberrations. So high-order aberrations have to be there, but I'll tell you some experience of mine. Tear film analysis, macular status, and the rest of it all remains the same. So this is one example where I'm showing no financial interest, where I'm showing anterior analysis. He spoke about IOL Master 700. Here it is important that we get all the calculations. Here you can see that all the calculations are together. So you have the right eye, the left eye for comparison. You have total corneal power. So the anterior corneal power and the posterior corneal power are different in post-refractive cases, right? So that's what we want to understand. Angle kappa is more relevant in hyperopic than myopic LASIK. And of course, biometry, corneal map, and angle kappa. So you have a full-on display of both eyes at the same time. You can do, that is a Barrett calculation here, and there is a Holiday calculation here. You can see that also on that side. And now if you go to another case where you have total corneal wavefront, so you have a corneal wavelength analysis, and here you can actually look at the high-order aberrations, so you can compare biometry, you can compare corneal aberrations, and you get an idea of white to white. So you have full analysis in one shot of each eye, and this is important as far as post-refractive cases are concerned. So entire toric planning can be done together, and this gives you anterior corneal astigmatism, posterior corneal astigmatism. You can decide where to place your incision, and incision can be set manually. Again, if you are not getting an axial lens sometimes, if it is a dense cataract, sometimes you may not get a reading, you can do an immersion and enter it manually, and that itself will also help you. So as far as premium IOLs are concerned in post-refractive cases, one is keratometry, and two is looking at the corneal wavefront or a high-order aberration, which is there, which is important in a central 3 millimeter zone. So you can see there is an anterior curvature and there is a posterior curvature. And this changes in post-refractive cases or RK operated will not change so much as post-LASIK myopic or post-LASIK hyperopic. So that's important. And so you have a total anterior surface, posterior surface, pachymetry, and refractive index, and this will give you the total corneal power, which is very, very important for analysis. Again, as age increases, you have to look at posterior corneal astigmatism. So by age increasing, the steep meridian, of the anterior corneal surface changes in the direction from vertical to horizontal. Remember this. So the anterior corneal surface, as we grow older, from vertical becomes horizontal. The posterior surface really doesn't change much. So this is what is being found over the number of years. So what is important as far as refractive planning is concerned is, of course, to look at the ablation pattern. Sometimes you can have a decentered ablation. Very, very important to do topography. If you have a decentered ablation, you can still, there is a tricks of managing these cases. I can tell you later on what if time permits. But if you have a decentered ablation, be careful in selecting your IOL. Of course, look at the point spread function. Don't forget the point spread function is of the cornea, not of the complete eye. If you look at this point spread function of the total wavefront of the eye, it's wrong because cataract is going to contribute to that. Only look at the corneal point spread function. So optical biometry is a rule. Use any formula as mentioned. I like to use a Barrett, gives good results, and right now we are doing all of this quite well. Need to talk to the patient about expectations. Remember that spectacle independence is important for them because they've had LASIK for so many years. They want to be spectacle independent. And of course, what kind of IOL to use is the next step. When it comes to planning of incision, make sure you know where your hinge is. Sometimes you tend to go close to the hinge, and do not do LRIs on a femto in post-LASIK or post-refractive cases, because that's not going to work the same way. It's going to behave very differently. So it's better to do a toric IOL in case you want to do like that. Do not touch the epithelium. Post-PRK, of course, determine if there is any haze or not, and post-RK, you may need wound suturing. Here just an example of post-myopic patient, 55-year-old, done LASIK many, many years back. So you can see it's a long eye, anterior chamber is 2.63, length thickness is good, keratometry and white to white is good. So here we did an ACD calculation, is very, very important, and I'll tell you why, that you have to look at ACD. As per a study, deep ACDs given in a toric IOL corrects a lower amount of corneal cylinder when it comes to myopia, and when it is a hyperopia, it's exactly opposite. So look at ACD when it comes to correction of IOL. Now this IOL calculation for the same myopic patient, you can see that we went ahead. The Barrett said 22, so Anterion also said 22, and I did multiple calculations. So ASCRS calculation 22, ASCRS Anterion 22, and IOL Master 22. So you can do multiple calculations and yet get a conclusion. And this patient, I did go ahead with a 22 diopter synergy, and the patient was 6/6 part and N6. So patients with post-myopic, you should not have a problem. Now the question coming to hyperopic LASIK. This is very controversial. I have done trifocals in hyperopic LASIK. Theoretically, it's a contraindication. So don't worry about it. It's the mind which actually adapts. So do not just throw them out. I had a discussion, and now I have 12 eyes. Bilateral hyperopic LASIK with a trifocal IOL, and patients are extremely happy. So I'll just show one example. High hyperopia, shallow anterior chamber, PI done, patient has a cataract. So you can see it's a short eye, a very shallow anterior chamber, 1.92, lens thickness which is very high, and keratometry which was 43, and a white to white which is small. We did multiple calculations, and this patient underwent again a trifocal IOL, and you can see a 31.5. Again, a patient is 6/6 part and N6. So the myth that a hyperopic LASIK cannot have a trifocal, I think it's between our mind and our eyes and our science. But most of the patients do extremely well, and they're quite happy with it. Coming to post-RK, so you can see 8-cut RK. Here, of course, this is how the topography will look. Calculations are easier because the anterior flattening and the posterior flattening is equal. You can see it's a long eye. ACD is good. Lens thickness is 4.51. It's a flat cornea because the patient had RK, and a white to white is large. And here, of course, the patient went ahead. So you do a multiple calculation. You can see that 24.5 max is 25.57. Again, we look at the EKR. The Anterion Barrett said 25, ASCRS said this, and I use the 25.5. Of course, you're targeting a little bit of myopia because there is a shift in these patients. So to cover up that shift, you go ahead and do this. Okay, I'll just take a second more. This is just a case where the patient, if this plays, I don't think it's going to play. So that saved, it's going to play. Very good. So this is a femtorexis, again, post-refractive and a trifocal lens going in. The beauty of a femtorexis, controversial. Those who don't have it will say not necessary. But I've been doing femto now since 9 years. And if I had my own eye, I would definitely do a femto because IOLs center automatically. The rexis is made in the center of the bag. When you put the IOL in the bag, the IOL just centers. You don't need to nudge it to center it. So aberrations, very, very important. This is our friend Amar, who's invented the pinhole pupilloplasty. If you have high order aberrations, you can do a pupilloplasty, small pinhole pupilloplasty, and it removes and improves the quality of vision. Of course, imaging is important as far as this is concerned. So we look at the angle, which is very, very important, whether it's myopic or hyperopic, and look at high order aberrations, refractive surgery, and all the other parameters are needed. Thank you all for your attention.
Thanks a lot, Kumar. Maybe we can take up a discussion if Kumar is still at the end of the session. Atul, we will follow the schedule right now. So Atul, your slides, he'll be talking to us on contemporary tools to optimize toric outcomes. I think you have to set timer as 8 minutes.
Hello. Good morning. At the outset, I thank Dr. Arup sir for giving me this opportunity. My topic is contemporary tools, strategies to optimize the toric outcomes. Before I shall to start with the slide. Yeah, to start with, I just want to see why we need all this optimization. You have to understand the new mindset of the patients. The cataracts are going for the decades, but now the patients after cataracts want to see what they see before they develop their cataract. So you have to be very much perfect in your outcome. Though the advances in biometry, intraocular lens, and the surgical techniques, they have improved our refractive outcomes. But the post-operative astigmatism is a major cause of poor post-operative uncorrected visual acuity. And so we have toric IOLs to combat for that. Calculating the best intraocular lens power for patients undergoing cataract surgery remains a key part of achieving a patient satisfaction. If you see the factors that contribute to the inaccuracy in calculation of an toric IOL, it's either an inaccurate measurement of anterior astigmatism, variability in SIA, an incorrect estimation of the posterior corneal astigmatism. There are so many toric calculators, so maybe not using a proper toric calculator, and there are some special situations. So if you go with the first thing, that is the inaccurate measurements of corneal anterior astigmatism, there are two issues in keratometry, tear film related, and there is a variability in axis and power. You know that the same instrument gives different reading at different times, or even if the amount of astigmatism that is calculated with different instruments is not exactly the same. So to tackle this issue, we know that there are so many instruments where you can measure this: a manual keratometer, auto keratometer, optical, corneal topographers with placidodisc. Then we have an OpScan initially few years back. Then we have a slim plug camera systems like Pentacam, Wavelight, Galilei, and Sirius. And to add to the list, we can have a keratometry from the vapor and aberrometry and a ray tracing also. The tear film related, we must understand due to the variation in ocular surface, keratometry has the potential to be one of the least accurate part of the measurement process, because it's a dynamic. In addition, as we get older, the ocular surface becomes less stable. So that many of these placidodisc measurements, they are very sensitive to these tear film irregularities. So what are the tools or the strategies that I use to optimize this issue of calculating the anterior corneal power properly? Take a reading on a virgin cornea. It should be quick reading. There should not be any rubbing on the cornea. The centration has to be proper. And see to it that the axis consistency is more rather than a power. You may have a little bit variation in the power, but the axis has to be consistent. That means you are taking a good reading. Regarding the another, what you have to have some pre-operative screening. Like if you are calculating the things, there are some red flags you should know. If the axial lengths of the two eyes differ more than 0.1 millimeter, if the keratometry differs with more than 0.5 diopter difference, and if the IOL power difference in the both eyes more than 1 diopter, think that something is wrong. You have to take again the repeat measurements. Maybe you can use a corneal topographer, maybe you use another instrument to calculate the things, so that this is giving the red flags. And regarding the uniocular criteria, you should look when you do a keratometry with an optical biometer that the standard deviation, it is there. It has to be not more than 30 micron. It is almost equals to 0.2 diopter. And also you have to see that the signal to noise ratio for your axial length measurement should be less, so that you can validate that the measurement that is been given is to the mark. If you find that it is not up to the mark, then you can take a measurement on a different instruments. So this way, regarding the tear film related measurements, do always warm compresses or lid scrubs, artificial tears to improve the ocular surface before biometry. And I think it is generally, rather than taking reading from 3 or 4 instruments, let us concentrate on one instrument with the proper validation of the criteria as said by the company, and the consistent results from the multiple measurements from the same instruments. The second factor that is a variability in the SIA. We all know that importance of SIA directly amounts the amount and the axis of post-incisional astigmatism. Even with a small incision and in the fixed meridians, this SIA is highly variable. So significant positive correlation is found between the preoperative corneal astigmatism magnitude and SIA. Means if you are dealing with a cornea with high cylinder, then the SIA may not be that which we are putting in a routine regular astigmatism cases. So we should customize SIA. Drhills.com site is there, and there are every surgeon should know his SIA, and it has to be calculated in the proper way. All the guidelines has been given properly at the site of the Drhill.com site. The third point, that is the incorrect estimation of the effect of PCA. See, the posterior corneal astigmatism accounts for 0.25 to almost 0.75 diopter, though it seems to be small, but it matters a lot in the premium surgery. And it not only alters the cylindrical power, but also alters the axis of placement of toric IOLs to achieve the emetropia. So this, if you ignore PCA, you will end up in undercorrection of astigmatism in against the rule and overcorrection in the cases with the rule astigmatism. There are so many methods to calculate the actual PCA measurements, but you can have toric calculators which incorporate ECA either by direct inclusion or by estimation with a fixed ratio. And there are some methods like they can overcome these inaccurate prediction errors of PCA with the help of different formulas. Now you can see this is a case, the astigmatism seems to be only 4.47, but when I calculate it comes to be around 1 to 1.25. So this is because of the PCA. There are so many toric calculators we know. Kane's, Barrett toric calculator with predicted and with actual measurements, Holiday's, Hopper QST, EVO. These all toric calculators, it has been found that the Barrett toric calculator gives it gives a very good result. The calculator with predicted PCA rather than with the actual measurements, putting in the actual measurements of posterior corneal astigmatism and putting in the formula. Though it allows now the readings to be taken from the ASOCT or a Schlempeck device like IOL Master 700 and Pentacam, but studies had proved that the one which gives better result is the one with predicted PCA, like that. There are studies recently that the Barrett toric formula with and without PCA measurements using the IOL Master 700 and the Kane toric formula result in accurate and comparable outcomes. ESCRS sites have a one-stop solution. You put a data there of your keratometry readings, and you get at a one set the 4 calculators readings: Barrett, EVO, Hopper QST, and Kane. So you can have, you just don't have to put readings in different formulas. You had one-stop solution for that. Now some special situations like the IOL spherical power also influences the cylindrical power at the corneal plane. So it means if you are dealing with an eye with a high axial length, or if you are dealing with an eye with a short axial length, these also matters because the cylindrical powers varies according to the spherical power of the cornea in a very high cases.
We'll have to move on. No?
Yeah, last slide. Regarding the corneal refractive surgery, already sir had given this. So can we reach 100% accuracy? The unfortunate reality is now that we cannot get, because we have a limitations. The accuracy of our measurements has limits. We are measuring a live changing system, and there is a limit to our ability to predict the IOL, where the IOL is going to sit. So accuracy of 0.5 diopter is also supposed to be a gold standard. So that is at the end we can say that though we with an IOL calculation formula we have an accurate power, but there are so many factors in giving the perfect toric outcomes. Thank you.
Thanks a lot, Atul. And we move on to the next talk. Ramesh, cutting edge technology is the topic. Yeah. So basically, Ramesh, I think you have to go that side. Yeah. So basically, you know, the ESCRS calculator, which was launched the year before last, is very effective. Like if you want to compare multiple formulas, not all formulas are integrated there. Whatever formulas are integrated, they give you in one screen. You know, what are the...
It's not moving.
So, yeah. So earlier on, we used to go to each website, take printouts and compare. So that has become a very useful boon for most of us. So over to you, Ramesh.
Can you get me a pointer, please? So this message came in the EWS group sometime back. Please advise, I performed an uneventful phaco with a multifocal IOL 20 days ago, but the patient came back with around 0.75 to 1. Patient is not happy. What is the best option? This question came up. Now, this is something that we all face if you are aiming for plano. We should realize that Douglas Koch in last year's CRST, cataract and refractive surgery times in 2023, said that 90% to 92+% is probably our ceiling. patients must be informed that they have a 1 in 10 to 1 in 20 chance of having a residual refractive error. Let us accept this. There will be some of our patients with a residual refractive error. My talk is on. Thank you so much. Thank you. My talk is on high-tech solutions for calculating the intraocular power. So there are low-cost solutions which is applicable to all, wherever we practice, whether in a small village or in a small clinic. And we have high-cost solutions which is more applicable if you're in a corporate setup. So we can use cutting-edge tech which are low-cost everywhere because it is online and it is free. Dr. Arup had mentioned about the importance of corneal power. This is very, very important, and because axial length measurement is no longer the key, we have to improve measurements of the cornea. The low-cost, high-tech way of doing this is to use warm compress for at least 1 minute, and ideally for 10 minutes daily for a week or two before you take your K, followed by gentle cleansing with a baby soap so that it doesn't burn the patient. You can do this and put artificial tears. This is a low-tech way. This is a low-cost, high-tech way. The high-cost, high-tech way, the costly way, is to use microblepharoexfoliations, dermabrasion machines, IPL, and LipiFlow, and equipment like that to improve the tear film. Axial length is the next most important measurement, and as Dr. Arup clearly told us, all optical biometers will give you the same very good axial length measurement. The importance of using an SSOCT-based device is that they can acquire data in the mature cataracts and the white cataracts. It's not a problem. I personally compared IOL Master 700 and Tomy is much, much better than IOL Master 700 in white and in hypermature cataracts. This is a 2023 review of 4 different optical biometers, and their conclusion was very simple. The Argos was able to capture valid readings in all those very dense LOCS grade 3 cataracts and white cataracts, while the IOL Master and the Antirion came next, and the Pentacam could capture valid readings in only 2/3 of these eyes. The other advantage of the new generation optical biometers is they give you a lot of additional features which prevent us from making simple errors. For example, they have multiple checkpoints. So they will show you the K like this, and you know that the tear film is not good, and you have to ask the patient to blink, or you have to optimize the tear film before you do the surgery. This is one more patient. We're all scared about posterior polar cataracts, and we feel compelled to tell the patient you may need to have a vitrectomy. But with the newer quality biometers, is not necessary because they'll give you an image of the posterior cornea like this. So PPC with an intact, nice, smooth posterior cornea like that, you can go ahead with your routine careful surgery. You don't have to tell the patient you have a risk of PCR. If you have a posterior polar with a small bulge like this, then you may have to tell the patient that your lens is a little weak. This particular patient came from Tiruchi after multiple anti-VEGF injections with a white cataract. On slit lamp, I could not see this, but with the IOL Master 700, you can see a nice posterior capsular tear. So PCR pre-op picked up by the optometrist with an IOL Master 700. So they pick up these small problems which we tend to miss on clinical examination. This is one more patient with a very dense cataract, came for cataract surgery, had a small macular hole. So the newer biometers have these extra features which make your surgery easier. Now, we discussed extensively about which formula is best, and we have multiple AI-based formulas which are the future. There is no doubt about it. The pure AI are the Hill RBF, the Camora, and the Nallaswamy, and the Nallaswamy is from Kellogg University. The partial AI or the hybrid AI, where they have a basic theoretical model on which the AI refines it further. So there you have the Kane, Pearl DGS, Hoffer QST, LADA super formula. Full Monty website is currently not working. So this is a 2024 review of all the AI-based formula by Stoperia et al. And they found that many of these newer formulas have 1 or 2 or very few publications. But of those which have a number of publications which we can trust, Hill, RBF, Kane, and LADA's Pearl DGS, Kane is the best. So if you want to use one formula for all your regular patients, please use the online free, high-tech, low-cost Kane formula. Every formula is capable of improvement, and we have no idea which the best will be 1 or 2 years from now. So from Barrett, if possible, please switch over to Kane. When Kane cannot be used, in special situations, Kane cannot be used, for example, post-LASIK, or if you want to do an IOL exchange, please use the Barrett suite. there are multiple other machines. They all give you some extra information which may be useful in some patient. For example, this is a topographer from the OPD3. It tells you the pupil size in photopic and mesopic conditions. It also tells you how the astigmatism changes between photopic and mesopic conditions because of the irregular cornea. So in a patient with keratoconus, if you just take one measurement, you may think, okay, 2.38 cylinder, I'll put a toric lens. But when you see that when the pupil dilates, the cylinder and the axis totally changes, you will make a different decision. Expensive equipment, expensive maintenance. For example, this is the IOL Master 700, the cost before COVID, and today if you ask them, they'll list it at 40 lakhs. Now, this is fine. Most of us, we may be able to afford it. But a few months ago, the service engineer said that time is coming out wrong. We had to change the battery. And he came to change the battery. And then after 4 hours of effort, he said it is stuck to the motherboard. We had to change the motherboard also. So he changed the motherboard and gave a bill for 6.25 lakhs. For changing the battery of the motherboard of the IOL Master 700. So all this cost is future cost. It's not a one-time cost. And I think most of us after COVID feel that we should not get caught up in a situation like that. Our revenue streams have become uncertain. This is like, again, 2 weeks ago, from Bajaj Allianz, they have reduced somewhere about 12,000 and odd rupees from a cataract surgery. And you know the number of phone calls and the follow-up, we have no idea why they have done all this. So we are in a situation where revenue streams are uncertain and cost is going up. So think about this. So if we want to avoid all these health issues, it is better that you think twice and probably have a common center or have large groups to purchase this. Individual doctors, I think, may not be able to comfortably afford all this high technology. But the future is still very good. Wearable stimulators are there in the horizon. One example is a B-Vision project, which has not yet come to the market, but they are talking about this, where in the initial checkup, they will check your eye power and the aberration profile. Then they will use adaptive optics. Then they will simulate how this. Then you will wear a simulator like this, and you can walk around with this. And then you can put in an EDOF lens, a bifocal lens, a trifocal lens in that, a monovision. You can show the patient different options. Obviously not applicable. I think I have, time is up. So that's the future. Future is great. So please use low-cost, high-tech Kane formula for most of your patients. Thank you very much.
Thanks a lot, Ramesh, for your brilliant presentation. Suven, will you be there till the end or you have to leave? Huh? Okay. So we will again take up Suven's presentation. He is talking on long and short eyes. So I think Ramesh's presentation was quite valuable. We are going for a new optical biometer, Ramesh. A new OCT machine actually. So it has an optical biometer upgrade. So I was considering how much I have to pay for the upgrade and compared to how much I have to spend for the IOL Master 700. And it is a huge difference. And most of the results have shown that, I mean, if you already have a macular OCT machine, all these things that you mentioned, that can be taken care of. You don't have to have those features in your biometer. Yes, Suven.
Okay, so thank you, Dr. Arup. Like I say always, it's when he gives me the topic, I curse him, and by the time I finish preparing for the topic, I'm a lot wiser, and I thank him for having chosen me for this. So, IOL power calculation in myopia and hypermetropia. I do not have a financial interest. I'm Suven Bhattacharjee. Now, the significance, I'm sure Dr. Ramesh has covered a lot, but there'll be a little repetition. So, Sir Harold Redley, we know, implanted the first IOL. It was minus 18 diopter spherical and minus 6 diopter cylinder that he landed up with. And later, Binkus introduced the 18 diopter pre-pupillary lens. Now, the patient was left with the same refractive error as he started with before the cataract surgery. So, merely an implant is not sufficient. We need to get it bang on. The accurate IOL power is necessary. And now, these are very wise words from Ken Hoffer. One group of ophthalmologists reads about the latest developments, stays up to date, and goes to meetings. That's you. And the other group feels more comfortable with what they have always used. Of course, they are not monitoring the outcomes. So, not much to talk about. It's absolutely decided that except where optical biometry cannot be done, the ultrasound biometry works well, but otherwise optical biometry is the first choice. Now, there are 9 types of eyes based on the size of the anterior segment and the axial length. There could be 9 permutation combination, and only about 73.4% fall in that median group. So that's where you get that point, the accuracy within 0.5 diopters. I think Dr. Ramesh has spoken about this. There are formulae over here which have evolved over the years. The first gen, which was in early 80s, and the second gen, where it was just a modification with a fudge factor, and the third generation, which were basically based on theoretical principles where geometric and optical characteristics were taken into account, where corneal power and axial length actually came into the picture. And then we had the fourth gen formulation, which actually held a strong position for a long time, the Holiday 2, the Barrett, and Olsen, and the Huygens, where various factors like axial length, corneal power, white to white, and AC depth, lens thickness, and patient edge, and sometimes the patient's gender also was taken. Now, the newer fifth generation ones are where AI is used, and there you have a whole list, and these are still evolving. And like Dr. Ramesh already just said, Kane is one of the best, and Pearl DGS probably is almost comparable. Now, there was this time in 2011 when Wang and Koch published this optimization of the powers, the calculated IOL power. The reason was for long eyes, the current formula that were there then tend to select IOLs with insufficient power, leaving the patient a little hyperopic. So they proposed an optimization. There were actually one center and a two center. This is the final two center reading, where a small addition, optimization was done to the existing formula, where you actually could make modifications. Now, the problem is these are all what is called static formulae. The AI formulae are dynamic formulae. So in a static formula, when you do an optimization, you're just moving the entire curve upwards or downwards. So you really do not come to the desired horizontal normal. Now, when AI-based optimization is done, the formula changes. The prediction errors are minimized as the original starting formula is transformed into an updated formula, which becomes more uniform and stays within the range of the 0.5 diopter which you desire. So these are the generation of formula. Like you'll see, if it's a normal eye, pretty much most formulae will work. But if they're long eyes, then you have these Holiday 2, Olsen's, Barrett, and Hill RBF. Short eyes is a big question. We'll come to that later. So this is a wonderful paper published by Mallis et al. In 2018, where accuracy of intraocular lens calculation formulae was tested. And if you see this curve, may look a little busy over here, but look at the Barrett, which is there in purple, and actually the Wang-Koch optimization has been applied. So the continuous lines are the ones where the original formula was used, and the dashed lines are where the Wang-Koch modification was used. And if you see the green one over here, that's Hoffa-Q, is way off the charts. But with the Barrett, it's reasonable, and when the optimization was applied, it's come closer to the 0.5 diopter zone. Okay, so this is with the intraocular lens plotting prediction error, and when we do the axial length, again we have similar pictures. So the Wang-Koch modification did help, but still we were off the mark reasonably. Now, in short eyes, the concerns that we have are there's a small axial length combined with a high power IOL that we're using. So the margin of forgiveness is very little. So we will have large refractive surprises with a minimal shift in the ELP. And another big factor you must consider is tolerance of IOLs. Now, the manufacturer gives you, the ISO standards give you a tolerance range. Say 0 to 15 diopters, the range is 0.3 diopters you can err on either side. Let's say if you're choosing a 10, it could be a 9.7 or a 10.3. But 15 diopters to 30, it's, I think, 0.5. And above 30, it's 1. So if you've chosen a lens of 31 diopters, it could be either 30 or 32. You don't know what the manufacturer has made. So you could be really off. So the margin of forgiveness is very little. Now, these are two meta-analyses, both published in 2022 on short eyes. Fairly large studies. One was in the Indian Journal, and the other is in the International Ophthalmology. Now, the Indian Journal one by Srivastava and co-workers suggested the Barrett 2 did pretty well, Holiday 1 and Hill RBF did pretty well, but none of the formulae was found to be statistically superior over the others. Very soon after that, the same year, this was published. The other in International Ophthalmology was published. The new generation formula based on AI and ray tracing, where Pearl DGS and Oculix were found to be very useful. In long eyes, the concerns that we have are incorrect axial length measurements because of poor eye fixation and posterior cephaloma. Now, if you see there's a long range of eyeballs, and there's increased risk of prediction error because of the axial length. Now, if it changes it's about 26 millimeter. 1 millimeter increase in axial length will lead to an absolute error of about 0.1 diopters. But if the axial length is more than 33, it's a 1.1 diopters. That's a huge difference. And these are the incidence of posterior staphyloma, which is very significant, 30.5 and more. It's almost 35% of eyes have staphyloma. Now, when we look at the optical biometry concerns, the problem is that optical biometry assigns a global index of refraction. So greater the amount of vitreous, the more is the index of refraction contributes to the overall measurement. And that's where the error happens. And optical biometry will always overstate the axial length. Longer the eye, greater the error. But also, we must keep in mind that myopia is not always axial. So in ROP, it's mostly lens-derived, so it's a curvature, but it's high myopia is lenticular. Stickler syndrome, it's axial, whereas in Marfan's, it's both. Now, in long eyes, there are two meta-analyses. One is in 2018 and 122. In the 2018 one, for those times, it was good. It said that Barrett University was statistically, the errors in Barrett University were statistically much lower. So, so that was the recommended. But in 22, when we have, so like the AI-based newer generation formulae and Barrett 2 were considered to be better. So in summary, the accuracy of the refractive power of intraocular lens depends on the exactness of the IOL power calculation. Accuracy of the IOL power formula in turn depends upon the axial length and the corneal curvature. As of now, still there is no consensus in the literature. It is a constantly evolving field. A review of literature will always help us since it's dynamically changing. The Barrett 2 is best among the Virgin's formulae, and Kane and Pearl DGS are the best among the AI as reported presently. Thank you very much for this opportunity.
Thank you so much, Suvan, for covering a large topic in a span of 8 minutes. Next speaker, Dr. Meena, IOL power issues in posterior segment diseases. Actually, Hoffer Q, I read somewhere, it is a formula which Hoffer Q wants people to disregard. It has to be abolished. But people still have been using Hoffer Q. In fact, the recent publications also see that. So he came up with Hoffer QST formula. So that was adopted by the ESCRS website, and I think it is we should be using it. It is a free formula. If you go to the website, you get it free of cost. Transcription errors have to be avoided, but I think it is a very good formula too, and serves all kinds of purposes. It's a kind of a lens suite, IOL power suite. Over to you, Dr. Meena.
Good morning, friends. I'll be speaking on a special situation when patients with a posterior segment disorder undergoes cataract surgery, and I thank Arup for giving me this opportunity. There are certain clinical scenarios that we deal with. We would be performing phaco in a vitrectomized eye or a combined phaco-vitrectomy, or the phaco could be combined with a silicone oil removal, and there is again the post-buckled eye, which have to be dealt with. When you look at the IOL consideration in patients with posterior segment diseases, these are the few challenges that we face in the axial length determination. There may be variation in the depth of the anterior chamber depending upon the tapenade agent that has been used, and this would lead to a variation in the final IOL position. Certain adjustments have to be factored in the appropriate IOL power that we use in patients with posterior segment diseases. The most important cause of error in IOL power calculation is the error in the axial length measurement. It could either be an overestimation or underestimation of the axial length. The axial length could be overestimated in a silicone oil-filled eye, where the sound is dampened because of the higher refractive index of the silicone oil. It could be underestimated when you are using an ultrasound biometry in a patient with macular edema, where phaco-vitrectomy is performed. And again, an underestimation of the axial length while using the optical biometer can occur in dealing with a patient with a very bullous rhegmatogenous retinal detachment. This is because the laser produces a good signal-to-noise ratio from the detached retina, and when there is so much separation between the retina and the retinal pigment epithelium, you get an underestimation of the axial length. In such a situation, it is best to perform the axial length measurement with the patient lying down when the shifting fluid shifts to the periphery of the vitreous cavity, and you get a good axial length measurement. The ideal situation would be to perform a pre-vitrectomy biometry in all patients who walk in for a vitrectomy, especially in eyes where there is a chance that a silicone oil tamponade has to be done. The IOL power the measurement of the axial length in a silicon oil-filled eye is best with an optical biometer, and as emphasized by all the previous speakers, in any situation, if the optical biometry is available, that would be the best thing to opt for when measuring the axial length, because the optical laser does not interfere with the silicon oil and the multiple interfaces that an emulsified silicon oil could produce in the eye. However, when you have a challenging situation, such as a very dense cataract, the optical biometry would not be useful because the patient will not be able to fixate at the laser target, and in such a situation, we still have to resort to using the ultrasound biometer. If you are using the optical biometer, select the option of vitreous cavity filled with silicon oil, and the refractive index of light would change from 1.33 in the normal vitreous to 1.4 in silicon oil filled eye, and you effortlessly get a reading. But if you are using an ultrasound biometer in a silicon oil-filled eye, please bear in mind that the speed of sound in the medium is inversely related to the refractive index of the medium, and the silicon oil has a higher refractive index than the normal vitreous, and it reduces the speed of sound by approximately 36%. This would lead to an apparent lengthening of the globe and a longer axial length measurement, and we also have to bear in mind the fact that the patient may have emulsification of the silicon oil, which will produce reduplication echoes, and you have poor post-retinal echoes. The necessity to convert the apparent axial length to the true axial length, making adjustments for the speed of ultrasound in silicon oil-filled eye, has also to be borne in mind. If you have an eye like this, sometimes we see patients with a hyperoleon and very densely emulsified silicon oil. Measurement of the axial length using either the optical biometer or the ultrasound biometer would be very difficult because of the multiple interfaces that are created. If you are using an ultrasound biometer in a silicon oil-filled eye and you do not have the option in your machine to change the velocity gates, where all the gates are set at 1532, which is the velocity of sound in a normal media, then you would have about 10 millimeter difference in the axial length. In this situation, you have to have a corrected vitreous cavity depth by making use of a formula-based calculation, or you can use a conversion factor to convert the axial length that you measure in the silicon oil-filled eye to the corrected axial length. But if you have the option of setting the velocity gates in your machine, then you can set in the velocity gates to 1040 meters per second if you're using 5,000 centistrokes of silicon oil, or if you're using 1,000, it can be set at 980 meters per second. However, when you have a patient coming in from somewhere, we are not aware of whether the silicon oil in the eye is 1,000, 1,300, or 5,000 centistrokes, there is still, again, the margin for error. We again have a situation when there is an incomplete silicon oil fill and a presence of a retrosilicon oil space, which is filled with the posteriorly circulated aqueous. And this is maximum when the patient lies in the supine position and minimum in the prone position. In such a situation, you can either opt for performing the axial length measurement using the ultrasound biometer, the patient sitting up, or you can use a CT scan to measure the axial length. We have to bear in mind that the refractive index of the silicon oil is higher than that of the normal vitreous and almost closer to the refractive index of the intraocular lens that we put in the eye, and hence the silicon oil will act as a minus lens in the eye and utilize the power of the lens that you implant. This will account for a refractive hyperopic shift in refraction, which is maximum if the lens is a biconvex lens and least if you are using a meniscus lens. The planoconvex lens would come somewhere in between. Therefore, if you have an eye in which the retina is unstable and you don't plan to remove the silicon oil, where an indefinite tamponade is planned, it would be wise to use the rule of the thumb and add about 3 to 8 diopters to be added to the IOL power that is calculated to achieve metropia. However, it is prudent to counsel the patient about the myopic shift that is expected if there is a necessity to remove the silicon oil at a later date. The additional IOL power can also be calculated by using this formula, factoring in the refractive index of silicon oil, vitreous, the axial length, that is the corrected axial length that we measure, and the anterior chamber depth. We move on to the next situation when a phaco-vitrectomy is performed for a macular pathology, where it would be ideal to measure the axial length using an optical biometer, but if you're using the ultrasound biometer, there is a margin of error and a postoperative myopic surprise when the macular thickness comes back to normal, because the ultrasound biometer measures only up to the internal limiting membrane, and you have a thickened macula underneath that, and there is an underestimation of the axial length measurement. Also, there is a modification of the anterior chamber depth, which could occur when there is a gas, tamponade, or silicone oil fill. And in such a situation, in a patient undergoing a combined surgery, there is a chance of a slight myopic shift in the postoperative refraction, which could be due to the axial length error, measurement error, a difference in the refractive index between the vitreous and the aqueous filling the posteriorly circulating aqueous filling the vitreous cavity, and a modification of the anterior chamber length, and you have to compensate for the underestimated. Can I have my screen back, please? In the presence of an intraocular gas tamponade, there is a forward movement of the lens iris diaphragm, and the lens remains anteriorly positioned, fixated even after the gas has disappeared, which accounts for a myopic shift in the refraction. So you can expect a myopic surprise unless you correct for it. If you look at scleral buccal dyes, the encircling and segmental buccals produce a lot of biomechanical property changes in the eye, which could be a slow-growing process, which is supposed to stabilize by about 3 to 6 months after the buckling procedure, but in reality, it goes on for a year or so. The axial length lengthens by about 1 millimeter, and this accounts for too strong an IOL and a myopic error. And if you're taking up such an eye which has been buckled recently, it is prudent to wait for at least 3 to 6 months before taking up the buckle dye. And the more the axial length elongation is associated with a 360-degree buckle and extensive use of cryopexy. There are certain situations when the axial length is impossible to obtain. In such a situation, you can use a CT scan to measure the axial length, or you can go for an intraoperative biometry or an intraoperative retinoscopy, making use of the following formula to calculate the axial length. A lot has been talked about the accuracy of the new generation intraocular lens formulas. The newer formulas exhibited better prediction accuracy compared to traditional formulas. And these are the various situations that I talked about. The Kane formula works best in almost all the situations, except when you do a phaco silicone oil removal, where the Barrett Universal 2 has been found to be better than the Kane, and in post-buccal dyes, the Barrett Universal 2 is better. If you have an eye with an axial length of more than 26 millimeter, it would be ideal to opt for the Holiday 1 with a Bangkok axial length adjustments. So friends, we are dealing with an intrinsically challenged eye, where a full recovery, visual recovery may not be possible because of the basic vitreoretinal pathology, and we should spare no effort to optimize the visual outcome in these patients and not add to the patient's woe by implanting a wrong power IOL. I thank you very much for your patient hearing.
Thanks a lot, Meena, for the comprehensive coverage of the topic. And now we move on to the last topic, Dr. Nirupama, who is going to sum up the whole session.
A very good morning. After all those wonderful insights on optimizing IOL power calculation, I'm happy to sum it all up and give some take-home pearls. So to get the bang-on target refraction, the first and foremost, as we all discussed, was to tackle the ocular surface, treat any dry eye, and measure the keratometry on virgin cornea before application of any eye drops or contact procedures. When in doubt, always repeat measurements with more than one device and also with more than one formula. Interpret the raw data and compare for any asymmetry between the eyes for the axial length, keratometry, and IOL power, and watch for red flags when there are extremes in the measurements. And always take care of patient considerations and counsel them properly regarding the post-op outcomes. And we should always keep a track of our measurements and the post-operative refractive results in order to optimize the A constant, which will actually shift the power prediction curve and improve the IOL power calculation over a wide range of axial lengths. In toric IOLs, always choose a stable, consistent, and regular astigmatism in which the cylinder power on the spectacle refraction, it matches the cylinder on the optical biometer, topography, and also aberrometry device like the eye trace. There are so many toric calculators available, but the most popular and the one which gives accurate results is Barrett total keratometry toric calculator, because the total keratometry, it calculates the anterior corneal astigmatism, posterior corneal astigmatism, and also considers the central corneal thickness. So that gives the most accurate keratometry in toric IOLs. And this posterior corneal astigmatism must be taken into account. Otherwise, in with the rule cases, there will be an overcorrection, and against the rule cases, there will be undercorrection of toricity. And we should always remember that the cylinder power, it is different on the cornea, and when we order the IOL, in the IOL plane, it is 1.5 times greater. And for all toric cases, always we should also consider the age, because the astigmatism may change as the patient ages, and also whether it is with the rule, against the rule, and also the surgically induced astigmatism, which was emphasized, that all surgeons can actually calculate their own SIA by visiting the drhill.com site. Although the mean SIA now has been shown to be less than 0.2 mm for a temporal clear corneal incision by various studies, it is always good to keep a track of the surgeon's induced astigmatism. And whenever there is a rotation in the post-operative period, we have tools like astigmatismfix.com, Barrett RX formula, or the eye trace, which will actually help us in re-rotating the toric IOL and bringing it into the correct aligned axis. So the tools and technologies now, all of us know that the ultrasound biometers have been rapidly replaced by the optical biometers, which are working on different principles, but the most popular and accurate ones are the third, which are based on the swept source OCT, like the Zeiss IOL Master 700, the Tomy, or the Anterion. So these are the ones which are the best in the market at present. The newer technologies, as day by day advances, we see newer formulas coming into the market, and we have advanced AI-based formulas which have the highest prediction accuracy. So the study by Mellis et al. Showed that for the normal range of intraocular powers ranging between 17 and 25, most of the formulas will work correctly and give us the correct IOL power. But it's only for the extreme eyes, like the long and short eyes or other complex situations, where we end up with refractive surprises. And for post-LASIK patients or patients who have surface irregularities, we have the eye trace or aberrometers, which will actually give us the measure of the aberrations, and these tools actually help us to calculate the IOL power more accurately. We also have the intraoperative aberrometry, which is coming up, and that is also useful for the post-refractive surgery eyes to enable a more accurate prediction of the IOL power. And we have newer premium IOLs, and also we are able to customize toric and also higher power IOLs for our patients with the newer technologies that are available. In post-vitreoretinal surgery eyes, as Dr. Meena has mentioned, in silicone oil-filled eyes, there is always an overestimation of the axial length, giving rise to a myopic error, and underestimation in patients with macular edema or a retinal detachment. So in these cases, optical biometry is ideal when compared to ultrasound biometry. And in patients with silicone oil, it is also better to do the silicone oil removal and then do the biometry for the IOL power calculation, or consider the correction factor when using an ultrasound biometer. The target refraction for gas-filled eyes should be a little bit on the hyperopic side, because there could be a forward shift of the iris lens diaphragm, and scleral buckling always causes a globe lengthening by 1 millimeter, giving rise to a myopic surprise. So post-refractive eyes, we should know that the Barrett True K Universal 2 comes handy, because it considers the change in the Gould-Strand ratio, the optic zone, and also the astigmatism more accurately. For irregular corneas, again, there is a high chances of inaccuracy, and we should be extremely cautious while ordering the IOL. And we also have the equivalent K reading from Scheimpflug devices, which also enables calculation of the keratometry for different zones of the cornea, which will be useful in the post-LASIK eyes. And for short and long eyes, we should be more careful. In myopic eyes, there is a posterior staphyloma, which gives rise to a hyperopic refractive surprise. And for short eyes, the error results from the ELP calculation, where even small errors can give rise to higher errors. And even the IOL power is high-powered, which will give rise to a more inaccuracy. When compared to myopic eyes, the hyperopic eyes, we have to be more careful. Thank you.
So thank you, Nirupama, for the wonderful summing up. We still have a couple of minutes, and any questions from the audience? Anybody would like to, Ramesh, would like to contribute something? Yeah.
So good morning, sir. It's an excellent talk, sir. I want a doubt. So post-smile, as a lot of smile is taking place in the market, any IOL power?
Ramesh? Anything else? See, when we talked about the toric formulas, this used to be an issue because, the toricity depended upon whether you're reading at the flat or a steep cornea or the antechamber depth. So now most of the formulas, even the company vendor formulas, they have taken that into account. So you don't really have to worry about whether it is a short or long antechamber depth or the steep or flat cornea. So these are all incorporated. Earlier with the Alcon or the Johnson & Johnson, their calculators had these issues. So they had to be, finally it had to be, recalibrated or recalculated manually. But now all the formulas have got this incorporated. So it is not really that much of an issue. And as Ramesh said, Kane formula has been doing extremely well, but is not as versatile as Barrett Universal 2. And so I think in the Kane and Barrett, they should go hand in hand. And when the Kane doesn't come up with results because of its limitations, then we can take from the Barrett Universal, Barrett suite. So thank you very much for your. It was an early morning course. We had starting glitches, but I think everything was handled well. And thanks a lot for your being present here early in the morning.